Everyone, just want to say thank you for coming to another ISKI webinar. Today we're focusing on study designs, and we have JD Smith from Northwestern University to present on that. So I'm going to go ahead and turn it over to him so he can get started.
I can turn it off. So today, as Brody mentioned, going to be talking a lot about implementation designs. So one of the things that I've done this presentation a few different times, both with Hendrix and Ninette Venbo, as well as a couple times on my own, where the focus was really on kind of large implementation trials, where randomization was typically possible, or quasi-randomization. So one thing that I did to make these align a little bit better with the 1 to 2 year pilot projects is I have a bit more of an emphasis on pilot, small n, and developmental designs that are appropriate for implementation research. So some funding acknowledgements. Of course, I want to acknowledge ISKI, which is funded by a supplement through NIAID to our Center for AIDS Research, as well as the Center for Prevention Implementation Methodology for Drug Abuse and HIV here at Northwestern, that's funded by NIDA. So some goals, pretty basic today. I really want to provide all of the audience with a basic understanding of various study designs for implementation research, both in the pilot and developmental stages, as well as some larger trial designs. I'm not going to skip over those, but they might be a little bit quicker since I know we have a little bit more emphasis on these earlier stage studies. And really the kind of goal too here is to help all of us understand and appreciate the key challenges in designing and conducting implementation studies. They can be really different from traditional clinical trials that most of us are pretty familiar with. So a few resources that may be useful, a number of publications that we in our group have done over the last few years. Some really kind of broad design papers are those first 3. So that top left one is recently published in Journal of Clinical and Translational Science. The one, the Design and Analysis and Dissemination Implementation Research, is a book chapter in the Brownson, Proctor, and Kolditz edited volume. And then the Overview of Research and Evaluation Designs for Dissemination Implementation was in the Annual Review of Public Health in 2017. We also published a review landscape of project abstracts funded by the NIH in the area of HIV that can be really informative for what to do as well as what not to do, since we were really taking a critical view of what has been published and funded. There's also a review paper on single case experimental designs that I published back in 2012 that gives a lot of basics about that type of study design and may be useful for not even just true single N, but really kind of small sample sizes that might require multiple baseline designs or something of the like. And then we also published a paper last year on implementation methodologies for achieving scientific and health equity that was published in Ethnicity and Disease. And this really gives a few different methodologies for addressing health disparities or working with health disparity populations through an implementation research lens. I also want to draw everyone's attention to a resource that I think is available on the ISKI website. If it is not, it is definitely on the CPEM website that you see down there at the bottom right. This is about an 85-minute presentation that we did a couple of years ago that really is an overview of experimental design. So this is almost exclusively experimental, randomized designs, some not randomized, that are applied to HIV studies. So if you wanted to take a look at some of these more advanced designs for larger trials, we have this really nice webinar available. So just to kind of reorient everyone to some of the critical issues that we'll be dealing with today, I really like to use this slide about how the emphasis of implementation research is quite different from other types of research, particularly effectiveness and efficacy research. So in effectiveness and efficacy research, as you know, we're predominantly focused on the intervention and its effects on health outcomes. These health outcomes are typically at the individual patient level. They could be symptoms, functioning, incidence rates, or just aversion of new infections. But really the system itself that supports the adoption and delivery of that intervention sort of is in the background when we're doing effectiveness research. It's still the intervention that we're primarily focused on. And of course, we're going to measure outcomes related to the intervention mostly, if not exclusively. In implementation research, and this would include also like type 2 and type 3 hybrid trial designs, we flip the script. So the system itself becomes the thing at the foreground where the intervention sort of recedes into the background. It's not that we don't care about the intervention, it's just that it's been well established to be evidence-based. We know that if we can implement it with fidelity, we're likely to achieve the clinical outcomes that were shown in the effectiveness studies. So now we want to focus on the system itself and the things that we do to support the adoption and delivery with fidelity. And because of this shift in focus, we're going to be evaluating different kinds of implementation outcomes, like the quality of implementation, the quantity, the speed of delivery, some other things around like reach, penetration rates, sustainability, all those things from either the REAIM or Proctor frameworks that we've covered a few times in our ISKI webinars. So just to reorient to terminology, so the NIH defines implementation research as evaluations of the use of strategies to integrate evidence-based interventions into real-world settings to improve patient outcomes. And really the kind of crux of this definition, and this is why it's NIH's definition, is that these studies and the kind of research is intended to produce generalizable knowledge. We also defined a new or kind of different area, borrowing words from other folks. So this is borrowing a concept or a term from Greg Aaron's work with the implementation preparation. But we defined this even a little bit further. We talked about studies that occur only within the implementation preparation space. And these are studies in preparation for a formal evaluation or test of the implementation strategies. And these could involve a number of different things. So studies that aim to understand implementation processes, the implementation context, and or the barriers and facilitators to implementation. Could also be studies that explore the feasibility or acceptability of novel implementation strategies, studies that develop or tailor novel strategies to specific contexts or for use with specific interventions. Also, the use of adaptations or adaptation frameworks to adapt evidence-based interventions for a context, a population, or maybe a new delivery method, like moving from in-person to more of an electronic or telehealth delivery model, or changing the actual delivery person, which is common in like task shifting interventions where maybe a pediatrician used to deliver it, and now we're having a nurse practitioner or a medical assistant or even a lay person try to deliver the intervention. It may require adaptation to do that. Implementation preparation can also include modeling studies, and this is usually simulation-based models. And these typically have the potential to inform implementation research or can be tested later in a formal trial. But within this context, they're not actually tested. They're just simulated, of course. So when we talk about design, this terminology or this term itself means a few different things in the context of this presentation. So design really refers to planned sets of procedures to do a number of different things. So it could be procedures that we have to select the subjects or larger units for a study, the procedures that we use to assign these subjects or units, and to measure their naturally chosen conditions if we're talking about observational studies or maybe quasi-experimental studies. And also procedures to assess measures before, during, and after assignment in the conduct of a study. This is a bit more applicable to quasi-experimental, experimental, and randomized study designs, but can also be appropriate for more developmental formative research as well. And before we get any further, I want to just kind of bring everyone's attention back to the legal, moral, and ethical responsibility that we all have to include communities and the organizations that we work with in the design and in the design process. So decisions that are made about, an appropriate comparison condition, about units that will actually be randomized, and then also who actually has ownership over decisions about the design itself as things move forward really need to be made in collaboration with and given co-equal ownership with the community and organizations that we work with. So some major areas that make this possible are to develop and maintain partnerships with a group of key diverse stakeholders. Also having the recognition that we're working often with under-resourced communities or other vulnerable populations that might have substantial historical trust concerns, and therefore we need to have them as co-equal partners. We also want to engage with the leadership in a partnered participatory research framework, as we know that that's a useful methodology here. And then also methodologic and design strategies that may apply when D&I research is conducted from a participatory stakeholder perspective is really critical in making sure that this can actually be done in collaboration with our community partners. So when we're talking about designs for implementation research, we're often talking about trying to understand or examine how evidence-based practices are adopted, scaled up, and sustained in community or service delivery systems. The NIH has their most recent PAR in Dissemination Implementation Research in Health, talks about the aim of identifying, developing, testing, evaluating, and or refining implementation strategies that are used to disseminate and implement evidence-based practices into public health, clinical practice, and community settings. And they explicitly call out a number of different designs that are applicable or at least acceptable to this area of research. They talk about randomized and non-randomized designs, hybrid effectiveness implementation trials, quality improvement designs for local knowledge, as well as simulation modeling approaches. So we'll cover each of these to some extent today with a relative balance on the quality improvement and kind of smaller non-randomized designs. So in general, there's a number of characteristics and challenges of implementation research trials, and I should say implementation research studies, not necessarily trials, that we kind of always have to pay attention to as we're designing studies. So one is that as we're moving into the real world and trying to figure out ways to actually make implementation work, we often value external validity over internal validity. In very controlled implementation trials, we may have a bit more of an equal emphasis on both, where we want to ensure that we've controlled for any confounding factors that may preclude us from being able to draw strict conclusions about the internal validity of the study. But we also want to make sure that we're not proposing something or conducting studies in ways that have no external validity. One of the kind of key terms that you might hear are things like pragmatic trials. These are really trials that talk about ways to change the conduct of the study in a way that maximizes external validity and makes it more like a real world translatable process than maybe we would have for a clinical trial. A principle that we like to always use is when you're designing any kind of an implementation study, you want to think about and try to minimize any disruptions to and burdens on the system as much as possible. In many of the situations, we are going to be actively asking them to change practice, change workflows, implement new things. So those disruptions are likely to be there. But again, there are still ways to potentially minimize how much it disrupts and burdens the system, both from an implementation perspective as well as from a measurement and some of the things that we might do purely to evaluate and do research on this initiative. Another really sticky thing that happens in implementation research is that if you are doing randomization or even just selection of different units of analysis or units of study, it typically occurs at higher levels of the service delivery system. And I say higher levels because it's really drawing in contrast to the traditional clinical trial where we randomly assign patients or participants at that level to usually to two different interventions rather than strategies. Because we're focusing on strategies and implementation strategies that target different levels within the healthcare system or the delivery system, we are likely to be focused on these higher level units, which kind of start at the provider level, could move to the clinical team, move into the clinic itself, the hospital, the healthcare system, the county, the state, the country, et cetera. There's lots of different units that could potentially be applicable. What often happens in these cases is we end up with a smaller number of actual units that we have to be able to randomize or evaluate. So we use some different kinds of designs to control for that. This also invariably leads to having nesting within multiple levels of the system. So if you have two different implementation strategies, one that targets the provider, one that targets like clinic workflow, and then you have patients obviously that are seen within that clinic and by those providers, you can see that we have at that point multiple levels. And even if you're not trying to intervene, those clinics exist within, the auspices of lots of different either national, state, or county level accreditation, as well as other climates and cultures that might dictate how well they implement or not. And we also always have to account in some ways for the interactions between these different levels, because certainly the way that the provider lives within the clinic and interacts with other people within it and its leadership is likely to have an impact, as well as the patient-provider and patient-clinic relationship as well. In experimental designs in implementation research, the implementation strategy is typically manipulated by the study investigators. This is really the independent variable that we would be looking at rather than the actual intervention, and I'll give some examples of this as we go. So some key things to think about when you're choosing a design. So what design type is required to answer your implementation research questions? The first thing really to consider is at what level in the system are the primary outcomes being measured? And this should align with the level that the implementation strategy is targeting. This will help you decide what the level and unit of analysis should be. The next question is, do you have sufficient units to answer your implementation research question? So if you're trying to actually compare and do analysis between either 1, 2, 3, 4 different conditions of different implementation strategies, you may actually need to have multiple units within each one of those different arms or different study conditions to be able to have sufficient power to be able to answer any kind of research question that you have. You also want to ask the question of whether or not it's applicable, useful, or appropriate, or even whether or not your partners will allow you to randomize the units. And this could be randomized to different conditions, or it could be randomization to implementation as usual, meaning they would not get the additional implementation supports that the implementation strategy arm would afford to the other units within the study. So this invariably leads also to a question about whether or not implementation as usual is actually even an acceptable comparison to your community or clinical partners. If it's not, there are a number of designs that do not have an implementation as usual control condition that we could propose. And I'll talk about these later, but predominantly we're talking about rollout implementation designs, as well as smart trials and some others, but those are the most common ones. So a little bit of guidance on when to use different kinds of design. So this is kind of 5 big buckets of different design considerations. They're not mutually exclusive, nor are they entirely distinct from each other. There are kind of a class of kind of more formative and developmental research designs. These are really intended for studies that are trying to understand the context, trying to select, tailor, or adapt strategies for testing at a later time in an experimental study design. We also have non-experimental designs, and this is typically observational studies. So I'll define those here in a second. We also have a class or category of within-site designs. So these are comparisons within the same unit, usually to pre-post or to just post. These are generally simpler. They're typically not randomized, but there are ways to do randomization if you have a couple different units or ways to actually randomize within a unit. You can also do between-site designs, where we compare between 2 different conditions or 2 different sites and examine the differences based on context, based on different implementation strategies that are used, many different variations here. This is a way to add replication or aggregation, which allows us to actually produce generalizable knowledge and more generalizable conclusions about study results. This is commonly used when we're trying to compare implementation strategies. Randomization in between-site designs can reduce bias, but you can also conduct between-site designs that are either non-randomized or have a quasi-randomization. There's also a class of within and between-site designs. This is more generally what we refer to as rollout designs or rollout implementation designs. In these kinds of studies, you randomize the timing, and potentially you could randomize the different implementation strategies. But one of the key considerations here is that in many rollout designs, there is no implementation as usual, at least not for the entirety of the study. All units will get the implementation strategy, or at least one implementation strategy to help implement the evidence-based practice. And then we have this big class of hybrid effectiveness implementation designs that, again, not mutually exclusive. Any of these other designs could include a hybrid effectiveness implementation component. There's many uses of these. Most common when effectiveness data is still needed as implementation is studied or evaluated, or when we need to collect effectiveness data for funding purposes or other external reasons. So a couple of, like I said, I added some stuff about small n implementation study designs. So some of the aims and purposes of using a small number of sites, and again, this is really kind of in the formative developmental work, is when you're trying to produce local knowledge. So really meaning what works for our situation, given our unique parameters. or when you're in the stage of implementation preparation studies. And we talked about these as being preliminary research on the feasibility and acceptability of novel strategies, when you're trying to conduct formative research to develop or tailor novel strategies. This could also be used when you're pilot testing the impact of a strategy, but typically in a non-randomized context, and also doing formative evaluation methods. And there's a couple of different really nice formative evaluation papers, including the Stetler paper from 2006 that's referenced here. There was also a paper from Ronnie Elwey that was published in Psychiatry Research in 2019 that's all about formative evaluation of implementation research. So let's talk about a few different kinds of research designs. We'll start with some observational formative research, simulation modeling, and contextual studies. Apologies for the excessively text-heavy slide here. So in observational studies, the intention and the goal here is really to describe outcomes of interest as well as their antecedents in their natural context. So in observational studies, as you would expect, we're not trying to change anything. We're not manipulating, we're not introducing new implementation strategies. We really are just observing the process of an implementation occurring, and trying to understand exactly what makes it work, as well as what kinds of outcomes are being achieved without changing anything. There's many reasons why this might be done. In certain situations, things are already being implemented without really understanding or knowing how implementation occurs. So we might want to do this as a baseline assessment to better understand what makes implementation either successful or not within certain contexts that would inform actual trials. This is also really useful for evaluating the real-world applicability of evidence. So this happens pretty consistently in our national partners, where something gets implemented without a lot of evaluation, but doing an observational study could help us actually see whether or not it's applicable and whether that evidence base really was translatable from efficacy and effectiveness research into more real-world situations. Concerning formative evaluation, this is really more of like a methodology than it is like a design. So in formative evaluation, the focus really is on rigorous assessment of process, designed to identify potential and actual influence on the progress and effectiveness of implementation efforts. The design aspect comes into the selection of different units, engagement of different stakeholders, as well as the process for doing an iterative evaluative process, as well as whether or not you're going to involve feedback to the system, which is not necessary, but is often done within formative evaluations where data is collected in an iterative manner where that data is then fed back to the system to then get a new iteration and continue to move forward. This is really useful in developmental stages when it may take multiple rounds or multiple engagements with stakeholders to identify the most appropriate implementation strategies, or in some cases to even identify what kind of evidence-based intervention they might want to implement. So formative evaluation can be very useful there. The methods that actually get used within formative evaluation are things that we're probably all somewhat familiar with. So things like stakeholder, expert, and community engaged activities like focus groups, stakeholder interviews, as well as just doing observation sometimes of clinical practice or of groups as they meet and discuss these issues. This can be really useful also for understanding the context of implementation. So it overlaps a little bit with the next big heading there around contextual assessment. It also can be very useful for selecting and tailoring implementation strategies. So some examples that have been done, a couple of different folks, including myself, have had funded projects for using the adapted ERIC process. So the adapted ERIC process is really a way to select discrete implementation strategies based on stakeholder engaged consensus or stakeholder engaged input, where strategies are put forward as being potentially feasible and potentially effective. Those strategies are then rated by all of the stakeholders on those two dimensions to prune down essentially the number of potential strategies. And then an expert consensus process is entailed to actually do the final selection of which strategies would go into a package or a multi-component implementation plan. So a couple of citations. The first one is currently published by Vivian Go in 2016. It was published in Implementation Science as a study protocol. And then I have a study protocol that is currently under review at Implementation Science Communications that I hope will be accepted fairly soon and we can share. In terms of doing contextual assessment, I know a lot of our pilot projects or a lot of our supplement projects are, at least as one component of their proposal, are doing assessments of the context and really trying to understand the barriers and facilitators or potentially the implementation capacity in their partner contexts. So what you're trying to do really in these contextual assessments is to really describe and potentially quantify characteristics of the implementation context. Often we're using things like the Consolidated Framework for Implementation Research Interview Guide, or the handy-dandy instrument review process that was done by the Society for Implementation Research Collaboration, led by Kara Lewis, actually identifies a whole bunch of quantitative measures for the different CFR constructs. So that's a really great resource if you have access to that as a member of the CIRC Society. In contextual assessment, we also want to understand barriers, facilitators, capacity to align with the evidence-based practice and the strategies and the outcomes. This was really, kind of central to the implementation research logic model and dovetails well with trying to complete that and fill it out in a logical manner. We also use a number of surveys. I have a couple of examples here, like the Implementation Leadership Scale, the Implementation Climate Scale, the Organizational Change Recipients Belief Scale, and there are dozens and dozens of others, the majority of which are all within that instrument review project that I mentioned from the CIRC website. Within contextual assessment, you can use formative evaluation methods, but you can also use a variety of other methods when doing this kind of research. So one of the most important things to really think about, particularly with the formative evaluation and contextual assessments, is that your sampling strategy is really critical for achieving appropriate representation of the variation that you might expect in the adopting sites, and the engagement of stakeholders at multiple levels can be really important as well. So these can be done within single sites, but it's unlikely that reviewers will be very excited about understanding one specific context, when the ultimate goal will be to have generalizable understanding of how and under what conditions implementation is going to be successful were we to actually try to take this to scale. So our next large category is misspelled simulation modeling. Apologies for the typo there. So simulation modeling is methods that we use to simulate the behavior of complex systems by describing the entities of the system and the behavioral rules that guide their interactions. What they're really intended to do is offer a solution for understanding drivers of implementation and the potential effects of different implementation strategies without actually testing them. So it can be a really helpful way to actually plan what would likely be more successful implementation studies or just implementation initiatives than if you were to test all the different combinations in reality, which would be not only time consuming and resource intensive, but probably unlikely to be funded because of the just extravagant cost. So some really nice examples of this being done within implementation science. The participatory system dynamics modeling that has been really led by Lindsay Zimmerman is a fantastic example where she goes into different organizations, works with leadership as well as on the ground folks to actually model the system dynamics within that particular clinic or unit. Then they actually plan an implementation approach that fits and matches with the dynamics of the system by actually modeling all the different combinations and different ways of doing it. So in that way, they're actually able to test in silico is what it's called, those different ways of doing it before actually doing it. And they've shown some really nice effects of this kind of a modeling approach. There's also kind of more traditional, like network-based mathematical models that have been applied to implementation science problems, as well as agent-based modeling. And that's a kind of a newer emerging area in implementation research, but has a lot of promise because it allows for a bit more complex interactions between individuals or agents within the different service delivery contexts that we might work. So I would expect that these kinds of studies are going to continue to become more prominent. They are, in some ways, when you're building a model from scratch, they do take a fair amount of time, as well as some specialized knowledge of whatever kind of modeling technique. But again, that investment on the upfront and being able to simulate and plan something more effectively is likely to pay off dividends in the long run, especially for large scale implementations. So let's move into some within site designs. So within site designs are really intended to evaluate change within a single site, a single unit, but not really compare it to anything else. So there's a number of different design types for within site designs. One is, the most simple, is really a post design. So in a post design, you would only measure the implementation outputs or the implementation outcomes after the new evidence-based practice has been adopted. This is common in quality improvement and also is applicable in times where a particular setting has no ability to have a pre. So really introducing something that is completely new, you would not have a pre-evaluation or a baseline outcome that you could compare to. So post design would be the most appropriate there. We also have the pre-post design, which I'm sure everyone is familiar with. In this situation, we would likely compare the implementation outputs before and after a new strategy is used to deliver an evidence-based practice. This is also common for quality improvement initiatives where, from the baseline evaluations, there's an understanding or a recognition that implementation outcomes are not very good. And so additional implementation strategies may be added to test whether or not they can boost or improve those implementation outcomes, which would be a pre-post design. We also have interrupted time series designs where you can do single unit quasi-experiments, or you could also use multiple units within a multiple baseline design where it's really kind of trying to replicate the effect. It's not trying to compare necessarily across different sites like you would do with a between site design, but you're really trying to replicate the effect to be able to say that this is actually something that wasn't just a fluke within a single site. So I'll talk a little bit more about those here in a second. So an example of a post design, a research question that you might ask is, can using PrEP active referral model between a local health department's STD clinic and a PrEP clinic lead to more completed appointments with a PrEP provider? In this situation, our target population would be patients that have a negative HIV test in combination and selected risk factors, STD results that would indicate that they would be, essentially meet eligibility for PrEP. Our strategy is to use active referral, where our STD clinic provider receives consent from the client to provide their contact information to the PrEP clinic, who then contacts the client to schedule the appointment with the PrEP provider, therefore not leaving it entirely up to the patient to initiate that contact with the PrEP clinic. The comparison is nothing. You have no such services available at baseline. This is a completely new way of doing things. So there is no pre or baseline evaluation possible. So in this case, a post design was used. So here's an example timeline for a post design, such as the one we just described. So at the start, you have no PrEP service. You're not doing any referrals. So there's not even that ability to get a baseline evaluation. You introduce the implementation strategy, and then you evaluate or basically describe the impacts of that implementation, which in this case would be referrals to the PrEP provider, which would be an indicator of adoption, as well as the completion of the appointment with the PrEP provider, which is our target outcome. In a pre-post design, you would test the impact of an implementation strategy. And in this example, it would be to sustain PrEP usage in a local health department's STD clinic. So this came from an example that we had done in a prior study or prior workshop where we pulled actual data on local health departments' use of PrEP prescriptions or even just providing of PrEP within the clinics. So at that case, at that time, that data showed that there was 38% of local health departments that used PrEP. And the question could be that, could we actually figure out a way to increase long-term PrEP usage among those already adopting PrEP within the local health department? And that could be a pre-post design because we could see where they were currently operating, introduce an implementation strategy, and do a post-evaluation to see if that long-term PrEP usage was improved. In example 2, we could ask the question of whether or not we can improve linkage by adding a PrEP coordinator at the STD clinic who's responsible for identifying, counseling, and referring to a PrEP clinic. So this would involve, the PrEP coordinator being the implementation strategy and being able to look at linkage and retention and care as our pre-post outcome. So getting into interrupted time series designs, these are often called like single case or single N or, any variations or N of ones. But in this particular situation, especially when we're applying it to implementation research, single case, so to speak, is really a single site, a single unit, or even could potentially be a cluster of sites or units that are not disentangled or cannot be disentangled into smaller numbers of units. So this really is like a single outcome comprising potentially multiple things within it. The primary goal of interrupted time series is to determine whether there's a causal or a functional relationship that exists between the introduction of an implementation strategy and the observed outcomes that we might see. And three questions that you can ask and address with an interrupted time series design. The first question is, does the independent variable correspond to a change in the level of the outcome? We often call this a level change or a phase effect analysis. We can also ask the question of whether or not introduction of the independent variable corresponds to a change in the trajectory. This would be a slope change analysis, and this is trajectory again of the primary outcome that we're interested in. And then the other thing that we can do is ask whether or not change in one of our dependent variables, if we have two, is associated with change in another dependent variable. And what this would involve is actually a collection of two outcomes and doing what's called a cross-correlation analysis. I'm not going to talk about that today. It's a little bit esoteric, but it is kind of an interesting analysis if it is applicable to your design. So within interrupted time series, all of the cases or units provide their own control data for the purpose of conducting the within case comparison. Some of the requirements for doing interrupted time series is that you have an outcome measure that can be systematically and repeatedly assessed over time. The overtime assessment is incredibly important. I'm talking more about 5 to 10 to 20 assessment points, not 1 or 2 or 3 that would be common in just a pre-post design. You also have to be able to establish a baseline or a pre-implementation comparison. The general rule of thumb is that this needs to have at least 3 measurement points to establish stability, but 5 to 7 is sort of ideal. You could think about this as being like weekly or monthly like referral rates. So those could easily be used as your unit of analysis for your outcome assessment. In which case you would need like a 3 to 5 week pre-implementation baseline, followed by a 3 to 10 week maybe intervention period. And these define our phases. So we often have an intervention pre-implementation phase and then our implementation phase that we compare using kind of basic or somewhat advanced statistical methods. So here's an example of a very simple way of actually doing analysis of interrupted time series. This is a program called Simulation Modeling Analysis. It's freely available on a website called clinicalresearcher.org, in which case you enter the data. So on the left-hand side, you have your dependent variable. It's called variable 1. So you would enter that data in your outcome, and then the variable 2 is your phase data, which is where you enter dummy variables for your 2 phases. And unfortunately, I didn't do a good job of picking a window that showed the change. But essentially, the baseline is coded as a 0. When we introduce the new implementation strategy, we then start coding the data after that as a 1, so that you tell the program the 2 different phases of the analysis. What you get then is a graph that shows your actual data, as well as a vertical red line that shows where the introduction of the implementation strategy occurred. That's based on how you program the 0s and 1s. In this case, I also asked for the phase means. So you can see during the baseline phase, we had a much higher mean than we do during the implementation phase. And when you run a test, you get 2 important outcomes, which I probably can't point to them. But at the bottom of the statistical output box, you have testing for level change, and then you have testing for slope change. And as you can see in this particular example, this was actually real data from a study that we did. There was a significant change in the level between baseline and implementation phase, but there was not a significant change in the slope. It's almost significant, but not quite there. So that's a very simple way of being able to more or less just dispatch the null hypothesis. So here's a study example. I'm actually going to jump here to where this is actually a multiple introduction where you introduce the prep clinic within these 3 different clinics. So this is the prep coordinator. would also get introduced at this point, and you can see in 3 different phases whether or not the added benefit of having a PrEP coordinator within the referral to the PrEP clinic actually made a significant difference across these 3 different clinics. And the reason we have multiple clinics, as I said before, is being able to replicate the effect gives you higher confidence in being able to dispatch the null hypothesis. You can also use multi-level models to basically take multiple units that you conduct these time series analyses on and get an average effect. So this was a paper that was published in 2015 that I led, where we had 11 participants in a non-concurrent multiple baseline, and we were able to show a significant change in the trajectory and a change in the level between baseline and then the intervention follow-up period. So in summary, these post, pre-post, and interrupted time series designs are often used for novel interventions or novel implementations. The single site can demonstrate feasibility and initial impact, but you do need multiple sites for a full evaluation, and that is really an issue of internal validity as well as generalizability of the finding. These kinds of studies are rarely randomized, but it is possible with multiple units. I could provide that if anyone's interested. These are simple and useful. They're great for generating local knowledge and for generating hypotheses and plans for larger studies. I'm going to go pretty quickly through between site designs. These are designs where you compare outcomes between 2 or more sites. So very commonly we do a novel implementation strategy versus kind of routine practice or implementation as usual. These can be done in either a randomized or a non-randomized trial design. We also have kind of a special case of a thing called comparative implementation that I'll talk about in a second, where we're comparing 2 different implementation strategies for the same clinical or preventive intervention. Common group-based study designs that we're probably all very used to, like cluster randomized trials, are applicable. But again, I want to remind folks that if you're doing this, it is most likely that you will have to be randomizing at these units at higher levels of the system. You cannot do patient-level randomization with the majority of implementation strategies that we test. In some cases you can, so it's not a blanket rule, but it's more likely that it would need to be at the level of the implementation strategy would be your unit of analysis and unit of randomization. I'm going to skip this slide and get here. So when you're designing a randomized comparative implementation trial, this is a hypothetical example. So let's say you had a cluster or a group of eligible and willing STD clinics that you could randomize to 2 different implementation strategies. So in this case, we're going to randomize them to either integrate a PrEP provider into their STD clinic, or they'll be doing a strategy of referring patients out, which requires partnership establishment with an external PrEP provider. So as I mentioned before, in both of these different arms, the intervention is held the same. It's the PrEP delivery system that we're all quite familiar with. And we would also measure the same outcomes. So our primary outcomes would be comparable or equivalent so that we could actually compare and be able to say that it's the implementation strategy, not some other factors that were leading to the different outcomes that we see. Folks have probably heard of SMART trials. SMART designs are places that we can test and optimize implementation strategies. So SMART stands for a sequential multiple assignment randomized trial. These can be optimization of dynamic and adaptive multi-component implementation strategies, and really is intended to help us understand what is actually needed to achieve a response, essentially, or a high, whatever level we a priori determine would be considered response to the implementation strategy. This also allows us to evaluate implementation while responding to clinics' failures to reach impact. So rather than letting them continue to flounder like we might in a traditional RCT, we actually help them try to improve their implementation by introducing another strategy. So this is what a SMART design might look like. Again, I'm going to use the same example from that prior STD clinic, where we have ready and willing clinics. We randomize them to 2 different strategies, the in-house PrEP versus referral to PrEP, at which point we then evaluate after a period of time what we call the response non-response mechanism. So for those that had, in this case, high uptake, they would continue to do the implementation strategy that they were originally assigned to. For those within each of the 2 arms that had low uptake, so basically a non-response to that implementation strategy, we would re-randomize them to getting additional strategies. So in one case, we randomized them to the opposite implementation strategy. So maybe it was an issue of mismatch where the in-house PrEP low uptake clinics actually would respond if they used the referral to PrEP. Or we could augment the in-house PrEP with doing additional provider training and potentially like supervision and monitoring of their progress. And then the opposite is true for the other arm. So for between site designs, they're really used to compare the impact of different implementation strategies across sites or groups of sites. These can contribute to generalizable knowledge because we typically have sufficient number of units for appropriately powered comparisons and can do, really be able to say that it's a generalizable finding. What's really common is doing a novel implementation versus routine practice. This can be non-randomized, but it can also be randomized. When we do head-to-head comparison of strategies that we refer to as comparative implementation, some of the things that we strive for, as I kind of already mentioned, are equipoise. If we're able to randomize, we increase the internal validity of these study designs, but it's not always possible. And I've been involved in and actually led a couple of implementation trials where we did comparative implementation where at least one of the conditions was non-randomized. So it can be done and they do get funded, but there's usually has to be a really good reason and rationale for why that decision is made. I didn't talk about incomplete block designs, but that's something that you could look up. They're used when you have few units available to randomize. They involve randomization within different, kind of unique groups and then have indirect comparisons. But that's something you could look up and I can provide a citation for. And then as I mentioned, that there's these smart trial designs where you adapt to different differential response to implementation strategies. It does involve randomization by design. So there has to be a sufficient number of units to be able to do that. Our last kind of bucket of implementation trial designs are what we call within and between site designs, or also just the general class of rollout designs. The common characteristic of all of these is that it involves crossovers where all the assigned units begin in one condition and move to another. So that involves the within site element of the between and within site design. Then this crossover is repeated across all the units in the study or the clusters of units within the study with staggered crossover points, which comprises the between site element. So I'll show a picture of this in a second, but I think hopefully it's clear. These can be done using randomization, quasi-randomization, or even non-randomized assignment of the units, but you would have to have them actually start at different times. So the crossover really is when the implementation strategy will begin. And typically we control for any confounding effects by randomizing to when that would start. But there are situations where randomization may not be possible and people just get assigned to when they'll start based on when it's possible for them to start or when they have to start for various reasons. And again, the unit that you're measuring can be a singular actual unit. It could be a cluster of units. You could actually do matched pairs across the different rollouts. There's also other kind of designs that could be used as well. Some of the benefits of rollout designs is that it reduces logistic demands as well as the resources needed to deliver new implementation strategies across multiple units. We're currently using this type of design in an implementation trial that involves 126 small primary care practices. And as you can imagine, trying to provide implementation support for 126 small clinics at the same time is pretty much impossible. So we're randomly assigning them to 5 different staged rollouts or rollout clusters to be able to spread across our different resources so that we're not overwhelmed. There's also equity involved in rollout designs where there's a benefit to starting earlier, where you get to implement and provide the service to your patients or clients, as well as to later start, where the assumption is that the implementation is going to be better. Even though you've had to wait for it, it will likely be more efficient and more effective because it happens at a later point in a trial that they're able to learn from their implementation. This type of design is really beneficial to statistical power because you use the within and between site comparison simultaneously. And then you can also, in this kind of design, account for the effect of unanticipated confounders. Case in point, we have a current rollout trial that's happening right now that the COVID crisis interrupted our ability to roll out in the manner that we expected. So we have half of our sample is implementing our intervention within primary care, half have not started, and we have this, unanticipated natural confounding event that we can actually compare, the clinics that had already started pre-COVID to those that start after COVID as an additional, comparison within our trial design. Had we done it as a traditional group design and everyone started at the same time, we really wouldn't be able to understand the effect of COVID and the COVID disruption on the healthcare system to the same extent that we will in this rollout design. So before you ask, yes, stepped wedges are a very specific kind of rollout design. Not every rollout is a stepped wedge, but every stepped wedge is a rollout. In this particular example, the stepped wedge would be used to compare maybe two different strategies. So we have 4 or 5 cohorts of 4 clinics each, where within each of those cohorts, half of the sample is going to be doing one implementation strategy, half will be doing the other. In this particular example, our implementation crossovers are staggered by 6 months for each successive cohort. And as you can imagine, given the name, we arrive at this series of steps across the middle where you kind of cross all the crossover points, create steps in this diagram. And then you also have 2 wedges. So this is why these are called stepped wedge designs. And you have the within site comparisons that are repeated across all of our different cohorts. And you have the between site comparisons that again are across each one of the cohorts from Q1 of year 1 all the way to Q4 of year 3. So here's another rollout implementation design that has incomplete wedges. So you can see we still have steps that indicate our crossovers, but we do not have complete wedges. So this is not a stepped wedge design. In this case, we had 7 clusters of 4 clinics each, so 28 total clinics were involved in this study. In these incomplete wedge trials, some of the advantages over a stepped wedge is that measurement begins immediately prior, in this case about 4 to 6 months to the step, rather than at time 0. So what this does is it really reduces measurement burden on the participating sites. So if you look back here, cohort number 5 is collecting data and reporting data, and they know they're involved in the study, but they're not actually doing anything in terms of active implementation for 2.5 years. In this particular case, all of the study or all of the clinics involved, they don't actually start doing anything until 6 months before. And one other thing that you can do with this kind of design is it allows for the option of staged enrollment. This could be needed or it could be planned to achieve the full target sample. Hendrix Brown and myself have referred to these kinds of designs as cumulative trial designs, where these clusters are added over time as needed, or as I said, kind of by design. You can't do that with a stepped wedge because everyone has to be enrolled at the exact same time in order to have this T0 wedge represented. Another design that you could do is what's called a rollout of repeated pairs of randomized communities. So this again is lends itself potentially to a cumulative trial design, but also can just increase power when you have a small number of units, but you're able to actually randomize them as a repeated pair or as paired up, which can help reduce variation and increase power as well as internal validity. So that is the last slide. I am more than happy to take a couple of questions. We do actually have time today, in contrast to my prior one that I did not allow enough time. So if anyone has questions, I'm happy to answer them. Otherwise, thank you guys all for joining today.
Yeah, so JD, we actually have a couple of questions that came in the chats during your presentation. The first one I think I actually can answer is from Susan about if we are going to be able to give access to the papers that you mentioned, especially the ones beginning. And the answer I think is yes. We can post them in the community of practice, all of the presentation, a PDF of the slides, and we can also put some PDFs of those papers in particular into the webinar page. It usually takes me 2 or 3 days to get that, so look for that maybe on Monday. The next question is from Theo Sanford. And he was wondering, can the less rigid designs also be hybrid? And like by that meaning, can they also assess intervention outcomes?
Yes, the short answer. I do actually have a slide about this that I want to share because I think it's worth it. I have to find it. Yes, here we go. Okay, so I'm going to share this piece of my screen really briefly just to show you guys this, this slide. So one thing that's sort of a misnomer, and this is just a poor naming convention. So hybrid designs are not the way that the intervention or implementation is tested or evaluated. What hybrid tells you is what you're going to focus on, or rather the relative focus between implementation and effectiveness. So the answer to your question is unequivocally yes. You can do any kind of rigorous or non-rigorous design that has questions focused on both implementation and effectiveness simultaneously. When you're, I think what the confusion comes in, and again, this I think is just a poorly chosen word choice by Curran and colleagues, is that hybrid designs are always accompanied by a quasi-experimental, experimental, or observational study design, like a cluster RCT, a SMART, or some other kind of rigorous or non-rigorous design. So I think that's where that does kind of get confusing, but absolutely, yes, you can focus on both simultaneously.
So the next question, also from Theo, was how does the implementation research logic model relate to a hybrid type 2 design?
Yeah, I think similarly, one of the reasons that we included both implementation outcomes and clinical outcomes is to really facilitate all kinds of hybrid designs. So again, like the hybrid 1, hybrid 2, hybrid 3 really just tells a reviewer and tells a reader what the kind of balance of your focus is on. So in a hybrid type 2 in particular, or a type 3, you would want to have a well-defined as well as a evidence-based set of implementation strategies. So that is really applicable to the implementation research logic model, where a hybrid type 1, you may actually not be proposing any implementation strategies from the outset, but you would be filling in the strategies that you observe and that actually take place in the conduct of an effectiveness trial. So it actually lends itself really well to type 2s and type 3s, and actually a little bit less to type 1s. We will circulate the slides. Another question that came in, if we're going to have a follow-up webinar to discuss implementation science questions related to the recent EHE funding opportunities. Good question. Nothing is planned as far as I know, but I think we could probably either put together some kind of a handout or resource. We can talk about that in our next ISKI planning meeting.
Hi, this is Florence. Yes, I have a question about the step wedge design. In your slide, you showed 5 sets of cohorts to determine when the implementation was rolled out from control to intervention. Is there a strategy to selecting those cohorts? Is it something like, do you combine small and large clinics? Or is there like a thought out plan for those cohorts, or do you even randomize within the cohorts to figure out who's going to start first?
Yep, so that's a good question. So I think most kind of randomization rules apply to rollouts and stepped wedge, where you want to achieve balance across each of the cohorts. So if you do have like a very heterogeneous like sample size clinic size in your sample, you'd want to balance to make sure that not all of the small clinics were all starting in the same cluster, or all the large ones were in a cluster. There's also ways to balance where you actually do matched pairs, or even just like matched quintuples, or whatever it happens to be, where you then like sort of cluster across the different steps. That gets pretty complicated, but really the idea is to make sure that each of those different clusters for each of the steps is going to be equivalent to the others. So lots of ways to do it, but yeah, that's a good question. I think one of the things you want to be careful about with stepped wedges and rollouts is that you don't automatically just go with all the clinics that are ready as the first cluster. that can potentially bias, obviously, the between site comparisons. All right, we kept you over a couple of minutes. Thanks for staying on, and I guess we'll sign off.